Good afternoon, Dr. Hopkins. This is Dr. Ahmed, one of the Associate Editors for CCI Journal here in San Antonio. I would like to first congratulate you on an excellent paper that's going to be our editor's choice for this issue. The paper is about Cabana study, which was a prospective study of carotid artery stenting in a moderate and high surgical risk patients with a 30-day follow-up. The patients enrolled were symptomatic as well as asymptomatic, and a total of over 1,000 patients were followed in this study. One of the questions that comes to mind, carotid artery stenting, as we all know, has been in the field for a while, still hotly debated about the indications and use. How do you think the planning of this study set up the stage for the answers that we got from the study?
I think the key to this study in terms of trying to look from the real-world perspective was just that, was to design a study that would include clinicians and a patient population that is seen in the real world in regular daily practice. And hopefully that would give us a better idea of what the outcomes might be post-approval in the real world. So that was, I think, the basis for designing the study. And it was a pretty standard FDA-based study with FDA regulations on who was high risk, and it was much like many of the other registries that were carried out. And again, the idea was to look at a sizable variety of patients and centers to get real-world data.
Thanks, sir. I was actually fortunate enough to be part of the study here at UT, and we did enroll a few patients. Excellent outcomes, very low adverse events. And you do mention in the paper, in the discussion part, even symptomatic patients had a very low, fairly low rate of complications. In your opinion, what was the major driving factor that we didn't see a major significant difference in the adverse outcomes between symptomatic and asymptomatic patients, which seems to be a concern in other studies?
Yeah, I think that's a great question. The Cabana study was a little bit later. I think that patient selection is absolutely critical in this disease, and I think as we gained more experience with carotid trials, we began to better select our patients, and by that I mean avoiding the patients that are extremely high risk for carotid stenting. I've always believed very strongly that carotid endarterectomy and carotid stenting are wonderfully complementary procedures, and most of the patients that you see that are at high risk for carotid stenting are pretty reasonable risk for carotid surgery. And a lot of that relates to the aortic arch. And I think that as we gained experience, by the time we got to the Cabana trial, I think the investigators perhaps had a little more understanding of who to avoid. I mean, just for example, if you look at the exclusion criteria in the original CREST trial, there were something like 27 or 8 exclusion criteria for carotid surgery, and only about 3 or 4 for carotid stenting. Today, there would be more exclusions for carotid stenting than there perhaps are for carotid surgery. So we're learning about who not to treat with carotid stents. That's one thing. Another thing that might play into it would be that there is some data out there suggesting that closed cell stents with smaller pores may be more protective in terms of preventing post-dilatation extrusion of plaque through the struts of the stent into the lumen and then subsequently embolization to the brain. So it may be that the studies that were done, I think in Belgium, it was the first one, that showed a benefit for the wall stent might well be coming into play here as well. Just better prevention of plaque prolapse because of the smaller pore size, and And as you know, we're now starting to see devices developed with thin membranes or very, very small pore size. And we think that one of the major problems that we face with carotid stenting, major unresolved problems, is embolization due to plaque prolapse. And maybe the wall stent is a little better for that than some of the other more open cell or larger pore stents.
Thanks, sir. I think patient selection, as you mentioned, very important. I think that ties into my next question. One of the key findings in your study was the operator experience, which you divided into tiers 1, 2, and 3, with least experienced to the most experienced. Ended up showing not any major difference. Would you comment on that? Was it better patient selection? Operators were more careful? What's your comments on that, sir?
I think it's pretty much the same phenomenon. I think we're learning, and people that are doing carotid stenting are talking back and forth, going to meetings, and more we're learning who to avoid with carotid stenting. And I think the fact that experience is now pretty much more widely known explains better patient selection and explains the results being just as good in the less experienced operators as in the more experienced operators. I think there's no question that there's a learning curve in carotid stenting, and to say that there isn't would be crazy. But a lot of the learning curve is about, aside from technology, is about patient selection. So I think it's probably a combination of more experience and better patient selection. Gosh, I think that the carotid wall stent is still, even though it's old as the hills, it still is pretty effective for carotid stenting. It comes on a very low profile and very highly flexible delivery system. Even though the stent is not so flexible when it's fully opened, the delivery system is very flexible when the stent is tracked up to the lesion. So that and the fact that embolic protection was mandated in this, like other trials, and add that all up, and we're getting better and better results with carotid stenting, and the CREST trial proved that carotid stenting is getting better. And I think if we repeated CREST today, we would see even better results with carotid stenting.
Completely agree, sir. And actually, that's kind of my last question: is what would you say a future carotid stenting study should be like? And we know that CREST-2 is in the process of enrolling patients and looking at carotid stenting outcomes. In our outcomes, what would you say? How would you design a new study, or what do you think we should need to learn still more from new future studies?
Well, I think that I'm a big fan of registries and collecting data and learning where our mistakes are, and then going on to the next registry and so on and so forth. The CREST-2 trial is a very aggressive attempt to get a clear handle on best medical therapy versus carotid stenting and best medical therapy versus carotid endarterectomy. I think it's going to be a challenging study. I think it's going to take a long time to recruit and enter all the patients. I think it's going to be particularly difficult in the surgical arm because surgeons don't have a whole lot of motivation. In the stenting arm, it'll enroll because patients don't have any alternatives now. And that's one of the fears that I have, is that the people who were doing a lot of carotid stenting, 5, 6, 7 years ago, have not been able to do it very much over the last 5 or 6 years because of the reimbursement scenario. And so we're losing experience. So we're gaining in judgment, but we're losing in experience. And I'm fearful that the carotid stent arm of this trial, it's hard to find operators who are really doing a significant number of carotid stents. And so that concerns me. On the surgical side, what's concerning is that most surgeons every time they enter a patient in this trial, are randomizing a patient to either surgery or medicine. And surgeons get paid for doing surgery. They're going to have to be willing to give up that paycheck in order to enter patients in this trial. So half the patients they randomize, they're going to lose the surgical fee. So that's going to make enrollment on the surgical side more difficult. The other part that I think is going to be a little bit of a wild card is patient compliance with medications, which is always a challenge. So I don't know what it's going to show, how it's going to enroll, or what it's going to show, but I think CREST-2 is a very ambitious trial, which will provide us with a lot more data, which is all good. I mean, everybody wants to see more data. I think this is an area, carotid stenting, where more data is not going to be, it's not going to be a big Waterloo for us. We've got tons and tons of data on carotid stenting. We know that it works. We know that it can be done safely in carefully selected patients. We know that it's a great alternative to carotid surgery, and that is perhaps the most compelling argument for providing reimbursement in carotid stenting. Because, I mean, I operate on hundreds of patients over my career for endarterectomies before stenting came along. They were clearly high-risk candidates and should not have had surgery. But we didn't have any choice because they were symptomatic, and we know that's a high-risk situation. Carotid stenting gives us a wonderful alternative to that set of patients that we know are high risk for surgery, and I think that for at least that category of patients, CMS would be well advised to approve carotid stenting for those patients, because I think right now they're being penny wise and pound foolish, because somebody has a stroke because they had an endarterectomy when they should have had a carotid stent. That's a disaster for the patient, for the family, for the reimbursement, for everything.
Well, thanks again, sir, for an excellent study. Great procedural success rate, greater than 97%, low complication rates. Appreciate your comments, and thanks again for spending time with us and sharing your wisdom. Thank you, sir.
Thank you.